I'd like to welcome you to the second of the 2021 sessions of CHIBA's Visiting Lecture Series. My name is Parminder Sachdev. I'm the co-director of the Center for Healthy Brain Aging at UNSW Sydney. Before we begin, I'd like to acknowledge the Gadigal people of the Eora Nation, who are the traditional custodians of the land on which our center stands, and I pay my respects to their elders past, present, and emerging. So today we are indeed privileged to host Professor Carol Brayne, a leader in the epidemiology of dementia internationally. Of course, many of you know of her work, but perhaps a brief introduction to say that her main area of research is in the longitudinal studies of older people following changes over time with a public health perspective and a focus on the brain. She's a professor of public health medicine and co-chair of the Cambridge Public Health Interdisciplinary Center at the University of Cambridge. She's a medically qualified epidemiologist and public health academic. So following her lecture, there will be time for Q&A. So through the talk, I'll request you to perhaps put in your questions through the Q&A function. You'll see a button at the bottom of the screen, and I will be monitoring those questions as they arrive. Thank you all for attending from around the world. And now I'd like to welcome Professor Brayne for her talk, Population Studies and Our Aging Brains Today. Professor Brayne.
Thank you, Parminder, and thank you for inviting me to speak to you today. I'll just check, first of all, that you can see my screen okay?
Yes.
Great. Okay, lovely. It's an honor to be invited to speak to CHIBA, which is growing in its stature internationally and doing such impressive work, and also your outreach program and communication programs, which are engagement with the public and society, I think are very impressive. So thank you. And I'm really sorry that I can't be with you in person, but we remain hopeful that we will emerge from the pandemic, and let's hope that we can build back better. So I'm going to take you through the experience and the learning that I've had over the last nearly now 40 years, not quite, of population-based research and the studies that I've had the privilege to lead, which have been multidisciplinary. So much of the work that I present is through multidisciplinary teams, which I know is a huge part of the CHIBA CHIBA aspirations. Now I'm just trying to forward my slides. Here we go. And I will really welcome questions from the audience, and thank you so much for being with us today. So what I've really tried to do as an epidemiologist and having trained in general medicine is look at populations across time and brain aging across time. And it's quite clear that life course conditions change. And Yu-Tsu Wu, who's a PhD student with me, who's now up at Newcastle University in the UK, did a piece of work which was reviewing population-based studies, and much of the data that I present today is sort of part of that type of work. But one of the things that she did was look at life expectancy in those studies where there was the ability to examine change in brain aging, most specifically dementia in this case, across time. And what she did was look at the changes in life expectancy. So this is the expectation of life in any 1 year. And it's created by, if you like, stacking up your expectation of life from 0 to 1, 1 to 2, 2 to 3, and so on. And that's what life expectancy is in any 1 year. So it's an artificial construct, but it's a very good way of getting a snapshot of what the mortality experience is in the population at any one time. And what you can see here is that there are profound effects on life expectancies because of shocks. And we'll see the same thing as we emerge from the, well, we've already seen the same thing with the COVID pandemic. But you can see that in populations, they're very different. and that depending on where you are in the world, the bottom one being African populations, sub-Saharan Africa, it's very, very different. And there's no reason why we shouldn't expect our experience of aging across the life course to be very different in the context of these changes in population life expectancies and the shocks that societies experience across historical eras. And in epidemiology, very often we tend to ignore this kind of historical perspective, and it's been one of the wonderful things about working in a field for such a prolonged period is the ability to try to really research those influences. And I'm sure I'll come back to that, and I'm sure many of you may have reflections on that approach. So we know that although there have been shocks and reductions in life expectancy at times in certain groups, such as young men in the First World War from many, many countries across the world, what we see here, and that causes an effect on the whole population, but what we see here is the anticipation of the changes in the structure of the population across time up to 2100. Now, the children the babies who are being born now, of course, are going to live into that period. And so we're talking about life courses now and the life courses of babies being born now. And what they may experience, as you can see, is in the yellow, parts of this graph. It's classic population pyramid, and with women on the right and men on the left, is that we do anticipate, and this is pre-COVID estimates, a huge rise in the number of people reaching later life, and then a huge rise in the number of people who reach the ages of 80 and 90. And this is a worldwide phenomenon. It's not just in high-income countries. In fact, high-income countries, although they'll see a great increase, potentially a great increase in the old, have largely done their demographic transitions, and the increases in the proportion of the population aged 65 and over will not be as dramatic as they are in lower and middle income countries. So at the time that I came into the field of brain aging and dementia was being articulated as a binary condition, very separate from brain aging. It was being, as it were, separated off. Up to that time, it had been very much entwined in literature, in societal observations, in medicine with senile dementia. But when you looked at the evidence base at the time, when I looked at the evidence base at the time in 1985, and at that time there wasn't very much. There was a lot of literature, but it wasn't anything like the volume that there is now. But when I looked at pretty well all that I could lay my hands on in 1985, which of course we didn't have in the internet then, the concepts were very similar to the concepts that we are exploring now, but with far less sophisticated methods, of course. But there was relatively little true population-based research going on. There were some population-based studies of dementia across time. At the time, across the world, but not that many. And of course, that's changed dramatically. And Chiba and Parminder have contributed to helping to bring that evidence base together more recently. What was very clear to me at that time when I entered the field in the mid-80s was that we need to examine older people in context, in population. I was training in epidemiology after medicine at the time, and it was very obvious from the training that I had that we can't really progress unless we understand disorders and diseases and health in the population. We can't really make progress in terms of improving the situation for people and individuals unless we understand the context in which these things occur. And as I've kind of reflected already, and I will come back to this again and again, dementia and cognitive change seem likely to change or be influenced by the context of history, community, and life course. And I just illustrate this with this beautiful portrait of an older woman, and one of our participants is part of who long since now has died, but a lovely photo that was in our local newspaper, a 5-generational study, just showing quite how different. Some people only have one generation alive and don't have any children, and others have 5. And the increasing longevity means that we have far more complexity in our understanding of what family means. And we need to clearly be aware of that in terms of the meaning and the impact of dementia for individuals. So as an epidemiologist, the very first thing is to define the thing you want to look at, the dementia syndrome in my case. And what I immediately found back then, and it wasn't as kind of clearly pinned down in those days, we didn't have all the diagnostic criteria, was that the dementia syndrome was quite clearly something which had fuzzy edges, and that those fuzzy edges were influenced by changing environments and fashions, which influence the syndromal thinking and subtyping of dementia. So you will hear in the media the language of Alzheimer's disease, vascular dementia, Lewy body, other hippocampal sclerosis, perhaps emerging a little bit now, and only just re-emerging are things like the mixed dementia. But in fact, these are really all quite challenging concepts, and that was apparent to me in 1985, and it's just as apparent to me now. The more beautiful techniques we have, such as with imaging, as shown in the preamble into the talk, imaging adds to our understanding of the complexity, and also challenges as we do more imaging and understand the role of different neurobiologists and neuropathologists, just how complex it is, particularly when we take that understanding out into populations. And I'll talk a bit more about that later. So into the mix of these rather dominant concepts, such as Alzheimer's disease and vascular, that have been very prominent over the last decades and are very heavily influenced by Western paradigms. We have now really re-emerging alcohol infection. HIV is clearly a very important factor, and potentially the medications associated with it. And COVID-19 itself, where there's a great deal of attention to neuropsychiatry and a concern that there will be an increase in dementia and cognitive impairment following the pandemic in the countries most affected with severe outbreaks. And of course, trauma has also re-emerged as being a very important factor, particularly with the elite sports people, but in lower and middle income countries, very important in terms of the usual exposure, as it were, exposure during life from more hazardous environments. So I really highlight this because there's this tendency to split and define into very narrow groupings. But in fact, we also need to kind of examine this from the population and always bear in mind that this is a syndrome, which is about cognition, ability to function day to day, and exclusion criteria, such as other reasons that might be influencing the expression of dementia. And all of those things are dimensional, and all of those things occur in a societal and a cultural context. So the way that we define the boundaries, the yes or no on whether somebody has cognitive impairment or different parts of cognition, the memory, language, and so on, what is it that defines normality and abnormality? And this is the stuff of epidemiology, basically. So it's important when we do population studies to try to pin some of these things down. But actually, the most robust way is to say, if you're working with a population, to say, okay, we have these things that we can measure. Those things make up the diagnosis of dementia. Let's measure those things as well as we possibly can, and not be hung up on the binary 0-1, dementia or not. And that was a difference in the 80s from the studies that had gone before. They tended to do dementia diagnosis, not dementia diagnosis. So from the 80s onwards, population dementia studies increasingly tried to examine as many variables as they could, which contributed to the diagnosis of dementia. And of course, that gradually emerged into studies with very deep phenotyping, as we call it, sort of deep measurement, so that you try to do a lot of different measures in the populations that you're studying. So this slide just really shows that thinking. So as an epidemiologist, I was taught to examine the thing. The evidence base suggested that dementia was not binary, and the syndromal criteria were very fuzzy. So we have to deconstruct the criteria and measure all possible variables. And so my very first study was describing in a whole but homogeneous population from a specific and stable area in north of Cambridge, the variables associated, which are required to make a diagnosis of dementia. And when you make a diagnosis of dementia, effectively, you study healthy aging, because you have to look for other conditions that may explain cognitive impairment and mental health as well. So you end up doing a very, very thorough examination of older people. And so at the time, of course, there wasn't imaging, and there really was much less in terms of deep investigation. But at the time, I used the two standardized instruments that were available globally, the geriatric mental state examination and the CAMDEX, that's the Cambridge Mental Disorders in the Elderly examination. And those were very carefully constructed instruments, very different in the way that they had been created, but they were standardized, and it was possible to examine whole populations in a standardized manner that is replicable. Whereas a lot of the other studies had worked on diagnostic sort of the field of clinicians rather than a standardized approach, or very simple scales. So I also did neurological examination, cardiovascular, and took blood in these women's homes. They were amazingly tolerant. I had my first child during this, and during this study, and in the end, sometimes it was more about the baby than the person, but it would last about 2 hours, and I spoke to an informant for pretty well everybody in that group. Very detailed interviews with informants, and usually trying to speak to a child or someone who not the partner, to try to get a kind of a relatively independent view rather than a spouse, where that it can be more difficult. So we also looked at simple and choice reaction times and IQ, and at the time that wasn't really part of a dementia armamentarium, but it was I felt very important because of theories that were emerging about basic neurobiology and fundamental neurological health, as it were. So this was called the E Cambs study, or the SOAM study. And what I found was that the dementia syndrome measures were continuously distributed. That means that in a population, there wasn't a binary distribution. So it wasn't either people had dementia or they didn't. It was a continuous distribution. And I had been taught by Geoffrey Rose, who was one of the great giants of epidemiology, that if you look in populations, things that appear to be binary in clinical settings are very rarely binary, and that most things are continuously distributed. You know, there's scales, there are spectra of almost everything if you go out into the population and look carefully enough and have good enough measures. Very few conditions are binary, and even something as what apparently binary as Huntington's chorea, biologically and genetically determined, does have variation in onset. Also, so there's all sorts of interesting contextual factors that can change even something that seems completely binary, such as Huntington's chorea. So even the aspects of subtyping that were available at the time, which was Hutchinski's vascular score, was continuously distributed. If you take away the requirement for dementia, the features of the vascular component are continuously distributed. And I found that age and education influenced performance, and this was a challenge to the standardization. If you apply blanket rules to the diagnosis of dementia, you will make curious decisions, shall we say, about diagnosis. And of course, this was found very much when applying Western methods, which include an assumption about education, to lower middle income countries, even also older populations in Western countries, such as in Europe. Some of the Spanish studies had women who had very, very little education, and you end up diagnosing far more people than is correct to a diagnosis of dementia if you rely on the cognitive performance for diagnosis, which many studies have done, use cut points and so on tests. So that was one early kind of illustration for me as an emerging researcher about the challenges to standardization when looking at populations and making diagnoses. So there's this need for standardization, but there's also the need to understand how these measures perform in different populations. And north of Cambridgeshire was no different. We have used very elaborate neuropsychological tests developed in wonderful tertiary settings, so very refined settings where people with high education tend to end up. And in my population in the rural Finland, not a single person was able to do the test. So, and yet it's absolutely clear that they weren't cognitively impaired. So there are huge issues to do with context in the nature of the tests that we use. So in a 5-year follow-up, we were able to look at prediction of dementia, and we found that informant and self-report memory problems were indeed predictive. They were associated with the outcome of dementia in those people who survived and responded at 5 years, which was quite a significant proportion of the original population, but that they would no way be useful to predict for any individual that they were going to develop dementia in the future. So, and that's the really big difference between looking at risk for groups and prediction for an individual. And this is where our findings are very important for screening in terms of understanding what it means for individuals and what it means for groups. So this is just a few of the, to illustrate a few of those findings. So this is the mini mental state. At the time, as I say, people were assuming that dementia and normal brain aging were dichotomous. So you'd have a double distribution, as it were, for the people with dementia and people without dementia. But here you can see that there's no kind of splitting off of the people with dementia. I mean, most of the people in the lower part do have dementia, but there's no clear differentiation. And you can see the clear separation of the age groups. And 70 to 74 are the clear bars, and 75 to 79 are the filled-in bars. And you can see that the change in cognition or the difference in age, because this is cross-sectional, the difference in cognition in the older women compared to the younger women in this study. Now, this looks very obvious now, but at the time it wasn't so obvious. The other thing that I wanted to look at, as I mentioned earlier, was this sort of the idea of a fundamental neurological integrity. And at the time, this was being just sort of mooted. Psychometric G, it's called. Basically, I examined it by looking at IQ cognitive tests. This is a long cognitive test, CAMCOG, and mini mental state is a shortish cognitive test. I think almost all the audience will be familiar with the mini mental state. Sorry, I didn't explain it in the last slide, but a relatively short cognitive test used across the world, reasonably well understood, very heavily criticized, but people sort of understand it. And it's simple reaction time, that's sort of a tap test for a 0-1 on a screen. Even in 1980s, we were able to do that with Felicia Huppert lent me her machines. And choice reaction time, where you have to, where there's a correct and an incorrect response and choosing a number. And all these tests are still around. It's kind of amazing, and still have value and utility, even though I mean, many of them have been sort of morphed into more sophisticated things. But you can see this is the correlation, and these are pretty high correlations. They're all very highly significant. And clearly reaction times are highly related, and IQ and CAMCOG are very highly related. But this sort of shows that there is a fundamental relationship between the speed of reaction times, IQ, which this IQ measure is supposed to measure pre-morbid IQ. So even if you're in the early stages of dementia, this particular method of reading out complex words and getting their pronunciation right is relatively good at identifying IQ, but it is pretty education specific as well because of the pronunciation issues. But you can see that there is a common thread throughout that. So there seems to be some good evidence there, and I think it's sort of been revived in recent years, the psychometric G idea, and fits in with much more profound and detailed examination of neurological systems that we're able to do now. So that was a very early study, but at the same time, an Australian called Daniel O'Connor, and Penny Pollitt, who some of you will know the names of, was setting up the Cambridge, what was called the Hughes Hall Project for Later Life. And the Jean Paykel, who's from New Zealand, Felicia Huppert from Australia, and I took this over in the late 80s to do and renamed it the Cambridge City Over 75 cohort. And it was population based in Cambridge City, so not in the rural areas, and people aged over 75, 95% response rate. And its original evaluation, its original intention was to evaluate community resource team impact on care quality and outcomes. And that was a policy initiative within the area to try to improve services and detection of people with dementia in need of services. What it led to was an increase in people being admitted to care settings, because there was recognition of people, of families and individuals' sort of distress in the community. That wasn't what was expected. The community resource team was expected to keep people more in their home. And sadly, that community resource team, which was multidisciplinary and as it now turns out, way ahead of its time, was dismantled because of Margaret Thatcher's policies of separating social care, social work systems from NHS systems, and it wasn't possible to continue an integrated care system. So very interesting kind of history there, which is very related to public health thinking and understanding whole populations and what's best for whole populations as people age and develop care needs. But this study actually provided us with an opportunity to not look at prevalence, incidence, risk, protection as well, driving behaviours, falls, frailty, end of life for neuropathology, and many, many people were involved, and I've just listed some of the names on the bottom of this slide. I'm just going to show you a few of the results. As I mentioned, it was population-based, it was community and care homes, it was over 2,500 people, and the methodologies were pretty similar to the ones I've described for the Cambridgeshire study, and we had as many surveys as we could. All of the participants who continued in the study have now died, and we had brain donation from 1988. This study contributed to the Eurodem exercise, as did the rural Cambridgeshire one that I showed you earlier. And this Bert Hoffman from Rotterdam, Erasmus at the time, now Harvard, brought together those population-based studies that I mentioned that existed in Europe that were truly population-based. They might have been a small locality like ours or a slightly bigger locality, but most of them were geographically based, and you can see where they were distributed across Europe. This study was hugely influential, and this is the prevalence data, and it's the same data on the left and the right. And what you can see is that it shows the rise in the prevalence, that is the occurrence of dementia in the population with age. And you can see this very sharp rise. You cannot dissociate dementia from aging, despite the fact that we have tried to do that over the last decades. And I'll come back to the reason why it's so important that we we never think about dementia without thinking about aging. And that's not to diminish the vital importance to the families and those with early onset dementias, but they are much, much rarer. So from a population point of view, it's very important to understand the early onset dementias because they are very special. But it's really important to understand for whole societies the impact of the increase in the older population because of the massive increase with age. The right-hand side simply shows this on a logarithmic scale, which turns it into a straight line, and it just reveals how dramatic the rise is with age. And of course, this is all well known to you, but sometimes I think we tend to forget it when we focus in on a very specific subtype of dementia like Alzheimer's or Lewy body. We tend to forget this contextual angle, and we need to kind of go zoom in and then zoom back out again to see the meaning of the research that's being done in the very specific areas. So that study allowed us to look at the distribution of change in cognition in a whole population across time. And as you can see here, Rose's mantra of things are continuously distributed was absolutely shown here. This is a nice continuous distribution. This is difference in mini-mental stage across 2 years in the population that we saw at baseline and 2 years in the Cambridge City over 75 cohort. So it showed that far from having a binary distribution with the people who are going to develop dementia kind of separating off, we have a continuous distribution. So we have whole change in whole populations. We were able to set up our brain donation program with the Cambridge City over 75 cohort with Angela O'Sullivan and Claude Wishick. And this was incredibly important. And we set up all of the methodologies that have been used in the bigger studies and things such as Brains for Dementia research. So I'm just going to show you some early work that we did to show this continuum in the brain as well as in cognition. So this is selecting out in a case control manner, which is a very standard methodology and much more what was being done from tertiary clinical settings, so sort of tertiary specialist clinics, if you like, where you would have people who have very clear dementia presenting and a very high probability of people being diagnosed with dementia who present once you get into specialist clinics. On the right, sort of we artificially from our brain donation from the population created a group with moderate and severe dementia. And then we looked at people who were like the people who would be selected for controls in a case control study, who tend to be volunteers or relatives of people who are presenting to clinical settings and can have quite serious biases. But this is just the kind of the people who are doing really well in the population. And what's the bars showing here, this is tangles, so Alzheimer type pathologies, plaques, and different types of plaques, neuritic and amyloid plaques. And what you can see is a nice separation, and you see a lot of these in clinical, in biomedical presentations about the separation of the diseased or the at-risk from the non-diseased or not at risk. And you can see it's beautifully separated. But in the population, if you put in the middle bits, the people who are on the minimal group and the people who are in mild group, this is clinical manifestations here, you can see that there is a continuum. Now, this is sort of old hat now, but at the time it was pretty radical. And people were really wanting to think that there was a big separation between normality and abnormality. But everything that I have ever done has suggested that it's much more complicated than that. Including looking at these deep biological phenomena of what do people's brains look like at death, according to whether they have experienced dementia during their life. And this is from CC75C as well. And this shows the different sort of major ways of looking at dementia subtyping in the brain. The Braak staging and the CRAD staging, they're just methods of doing it, but they're effectively Alzheimer type pathologies. And here you have the staging according to those particular methodologies or the amount of the thing. And here this is protein buildup in blood vessels that is associated with dementia in life, but particularly has been linked to Alzheimer's type pathology. And vascular disease more generally. And what you can see here is the people who have dementia are darker and the people who died without dementia are lighter in the histograms. And what you can see is there's just tremendous overlap between the different groupings. So other things are explaining the presence or absence of dementia in these very old people at death. And most of these people, they started off in the study at 75 and over. So most of these people are in their 9th decade, so 80s now, the brain donors in their 80s. And this is, of course, the age group, which if you think back to the prevalence slide, this is the age group at which dementia is most common. So then that's the CC75C studies. So then the learning that we had in the CC75C study and so on was then taken along with other colleagues from around the country, into the national studies, the cognitive function and aging studies, which are population-based, multi-site, multi-institutional. And this study had 18,000 people at baseline. And the methods were brought across from, as I mentioned, from the learning was brought across into this study. And we were able to get going with that in Liverpool in 1989, most of the other sites in 1991. And then in 2010, we were able to do a new generational study selecting from Ely, or the Ely and surrounding area north of Cambridge, Nottingham and Newcastle, to do a new generational study. And I'm going to give you some of the results from that, well, very, very collaborative effort. So just concentrating to begin with on the blue, and this is actually just from Cambridgeshire, Nottingham and Newcastle, because that's the comparison sites for the new generational study. The blue was the prevalence that we estimated in 1991 at the baseline with from those sites over 7,000 participants aged 65 and over, using standardized methodology, very carefully quality controlled across the sites. So it was a big national study, lots of people involved. And these estimates were used not in the Eurodem that I showed, but in later estimation for the UK and later international estimations of prevalence and incidence of dementia. In this case, prevalence results only. So this has been part of the highly influential prevalence studies internationally that have given us estimates for how much dementia there is in the world. And I'm just underlining on this because such studies are pretty difficult to do and they take a long time. And there aren't that many around the world that really are truly population-based. But once they're there, then they're used very heavily across the world and within country and within locality. So these were used to generate estimates for local policy making and so on within the UK as well. The new generational study is CFAS II here, and this shows you the prevalence in 2010 in the same populations, in the same geographical areas, I should say, freshly sampled, so 65 and over, freshly sampled, 2010. And you can see this very dramatic drop. And it is still the case that despite this dramatic drop that we showed in the UK, and I'll come back to other countries later, the rhetoric in the UK is almost always, this is hardly ever mentioned in the research world in dementia. It is really quite striking. There is, this study was designed to look for changes across generations. It has robust findings, which were presented at AAIC, the conference, the Alzheimer's conference, many years ago. As you can see, these are the data from some time ago. But it's difficult to penetrate the rhetoric and that's the more negative rhetoric, if you like, of tsunamis. So this doesn't mean that dementia is less common, because during this two-decade period between CFAS I and CFAS II, life expectancy increased very dramatically. So what we see is this, what we saw was an estimated stability of the numbers of dementia, not a massive rise in the presence of increased life expectancy. This is clearly very profoundly important, and we need to understand it better. The incidence rates also reduced by 20%, largely driven by men. And this background slide shows you the earlier incidence from CFAS I, and the light blue is the earlier incidence, and the darker one is the later incidence, showing the drop across age groups in the incidence of dementia. So this is a kind of major findings, and of course this, it's a 30 years in the making, even though it's just one slide. In CFAS, in the original CFAS, we looked at risk factors across for dementia in people who didn't have dementia at baseline and then developed dementia during the follow-up periods. And I mentioned age at the beginning. I'm going to mention it again now. The impact of age is very dramatic. So for a 90 and over year old person, the risk of developing dementia is 25 times that of a 65 to 69-year-old. And then there are other very important risk factors, but they pale into insignificance against age. So we must always bear that in mind, that age is highly associated with dementia, and so there are aging phenomena going on which drive dementia, as well as these modifiable, not some modifiable, some not, risk factors and protective factors such as education, which I'll come back to. So we have the Brayne donation in CFAS II, and we have from the original CFAS. Unfortunately, we weren't funded to do Brayne collection from CFAS II, nor to do extended follow-up. But we have collected well over 500 brains from the earlier CFAS. And there's a lot of neuropathological epidemiology led from Sheffield University by Steve Wharton, previously Paul Ince. And this work has contributed across all sorts of areas. And your own Michael Valenzuela from Sydney has also been a collaborator doing important work on cognitive reserve within this collection too. So there is molecular work going on. I'm not going to talk particularly about the molecular work today, though. One of the most important findings from the Brayne findings from the Brayne donation study in CFAS has been this looking at age, neuropathology, and dementia during life, because we're able to dissociate the neuropathology from the dementia, where our neuropathologists are blind to clinical status. So they assess the brains without knowing whether somebody had dementia. And this was actually a major battle at the beginning of CFAS, but it's one that now is routine, which is terrific. So we were able to look at how people express dementia before death and relate it to whether their age and whether they had atrophy and all the features of all the neuropathological measures that are made in a person at death in older age in relation to dementia. So here it's just illustrative with atrophy and neurotic plaques. But what you can see is that for atrophy, the relationship of atrophy to dementia is consistent. So the proportion of people who have atrophy, whether they have no dementia or dementia, rises in both, but the relationship between that rise is similar across age, but it isn't for neurotic plaques, and the same thing applies for other neocortical brain areas. So you can see that because the features of Alzheimer's become so much more common in people who die at great ages without dementia, that they begin to approach those who do die with dementia, where in fact the proportion of people who die with those pathologies goes down with age. So this is a very interesting phenomenon and shows that we absolutely must take age into account. That study also allowed us to look at the proportion of people who might be accounted for, or the proportion of dementia that different pathologies might account for. And here you can see that age, this is on the right-hand side, we have age, the proportion accounted for by the particular variable here, age, brain weight, Alzheimer type pathologies, vascular pathologies, and others. And what's really important here is that age is really important, brain weight is important. Alzheimer's disease pathologies accounted for only for 20%, they're all about 20%. Vascular pathologies for about 20%, and other pathologies about 15%, although that's risen now with hippocampal sclerosis, a little bit more there. And so this is a fairly crude analysis. It's quite difficult to do this work, and there's lots of interrelationships between these things. But this gives you a sense of the complexity of looking at dementia in older populations, and the importance not to assume that there's one pathology that explains everything. Another area that we were able to look at is the disregarded pathologies, and the detail here is less important than seeing that pretty well all of these dots are above the 1 line here, which shows that the people who died with dementia and without dementia had more of these pathologies. So the risks of having dementia with these pathologies, sorry, I probably didn't phrase that completely right. The risk of having dementia with these pathologies is greater if than if you don't. So it's all above 1, and these are corrected for other pathologies within these blocks. So at the time that we published this, these were not of great interest. So things like granulovacular degeneration, Hirano bodies, gliosis, and looking at different parts of the brain, so the cortical, hippocampal, and entorhinal, so the higher parts of the brain and the brainstem. What's striking about this is you see these changes across the brain. It's not just the cortex. So, and it's also there, the relationships and the increases are there, even if you control out the standard pathologies. So this is, again, adding to this complexity of understanding of what dementia is in older populations. I mentioned about risk factors and protection, and this slide shows you that if you have higher education when throughout life, so this is education in early life, how many years at school, basically, whatever your level of this particular pathology is cortical tangles, but it also is there for other types of pathology, the proportion of people who express dementia before death is lower the higher the educational level. So again, this is not about individuals, this is about groups. So if you're highly educated, it means that you're less likely to express dementia, even in the presence of neuropathology. But it doesn't guarantee that if you have high education, you won't die with dementia. But this is a very important finding because it contributes to the now very robust work going on about brain reserve and compensation. But what was interesting in this was I expected that the burden of pathology would be less in those people who had higher education, because that's a proxy for more privileged lives and less exposure to noxious things. But that wasn't the case. So it protected you from the expression of dementia, but it didn't protect you from the burden of pathology at death. But of course, people with higher education also die later. They have higher life expectancy. We've also been able to look at delirium, and Dan Davis, who's now at University College London, showed that the longitudinal trajectory of people in their cognition, whether or not they experienced delirium during their recent years, was quite different. So the mini mental state change in people who had no delirium in their history was much more favorable, if you like, than people who had experienced delirium. And that, looking in the neuropathology, was not explained by standard pathologies, standard Alzheimer and vascular pathologies. So that's another avenue of research which brings in the health course of an individual and the way in which it influenced their cognitive trajectory. Education also influences education, occupation, and late life social engagement also influence trajectories of cognition, not just education. And this slide shows work by Riccardo Marioni about the transitions from no impairment in cognition to slight, moderate, and severe. This is using mini mental states, so it's fairly crude, but the findings are pretty stark, which are you have much lower likelihood of going from no impairment in cognition to slight impairment if you are in the highest cognitive lifestyle group compared to the lowest, and you're much more likely to recover as well. So that's so this kind of advantage, the life course advantage conferred by things that have you've experienced during your life course seem to show how much better you can do in later life. And also when you reach severe impairment, this is in the cognitive function and aging studies, again, of course, you're more likely to die, or the participants were more likely to die. So these results are not in isolation. Others have shown similar things across time as well. So this is part of an international body of literature. I'm going to skip these slides because those we've been able to contribute to conceptual and methodological approaches in terms of the continuum and also the concepts of mild cognitive impairment, which are also fuzzy. So they basically show the continuum of the types of measures that we use, whatever you are measuring, and also the challenges of concepts such as mild cognitive impairment with lots of recovery out of cognitive impairment as measured by MCI. So just the latest kind of assembly of findings. Importantly, our CFAS study has contributed to Frank Walter's detailed analysis of the trends in dementia across time. And this was published last summer, bringing together a range of international studies, all high-income countries in US and Europe. And these show that there is this very clear reduction in the incidence of dementia per decade in these across these countries. So this diamond is well below 1 way, and so it's a really quite dramatic reduction across decades, and it is variable across genders, more obvious in the men than the women. So that's kind of bringing together of these long-standing studies. And within CFAS, we've also been looking at life course health and disability and life expectancy with disability. So this is bringing in cognition as well as physical disability, and this can't be separated out. So cognition can't be separated out from functional disability. It's inherent in the dementia diagnosis, but it's actually also inherent in aging to have these things, these factors looked at together. And this compares for men and women in CFAS I and CFAS II, and life expectancy, as I described it earlier, with disability and without disability. So the clear lines are without, with disability, and the filled in bars are disability free. And you can see that for those, and it's also by advantage, so going from most to least, and this is just published, showing that there is a gradient in both the earlier generation and the later generation, and that it has changed across generations. So that advantage, disadvantage and advantage are still very much there. And of course, COVID has massively shown that up in all our societies, or not perhaps so much in Australia, but certainly in the UK. The other area that we've contributed to in a major way has been the Lancet Commission type approach, with both with the methodology and then with the bringing together and contributing to the latest revision of it. And this very substantial work on looking at the world literature and risk factors. And the reason why I put this up is we've contributed in terms of understanding about risk factors and protective factors. But these factors are all very heavily associated with inequalities, so that if we want to do something about dementia in our populations, we really, really need to do something about inequalities from birth onwards. In parents and from birth onwards. This is vital for brain health across the life course. And that brings me to my final slides, which are basically the fundamental principles of public health with primary prevention, secondary prevention, and tertiary prevention, and also people in their context, that we cannot see these things in isolation. Everything that we do is a balance of these things. And in order to get the best possible outcomes for populations, we need to integrate them. So the reflections from this research are that dementia can't be separated from its context of person, place, time, and population. That it is complex, but it's not impossible to examine that complexity. We have really shown change across time, and it's likely that the underlying dementia has changed across time and is different across populations, but we have to look to know. We have to study to know. And future policy and research should follow the evidence. And I always show this slide because I think it's so incredibly important, and even more so in the time of COVID, that we, as researchers, we always bear in mind the contribution of our research to the Sustainable Development Goals across the world for all of our sakes. I'd like to thank all of the collaborators who've contributed to all of this work across the country, across the world. Too many to name, but most particularly Fiona Matthews from Newcastle University, who's been a key lead within CFAS across many years, and our funders. And thank you. Any questions? The views I've expressed, of course, are my own.
Thank you so much, Carol. That was a wonderfully thoughtful lecture. And I was quite impressed by the fact that you took us on a journey. And it was to some extent a personal journey, I would think. And then you placed it in historical context and so important for us all to appreciate the context of the research that we do, really. And especially for junior researchers, I think, to understand the context is so important, something we often neglect. So we have a few questions coming through. I have a lot of questions as well, but I'll hold them back and maybe go to some of the questions put by the audience. And here, starting with Viveka Katz. Viveka is a research officer at CHIVA. And she asks, okay, you talk about the decrease in prevalence from one generation to the next, but what about change in duration of dementia, the amount of time people live with dementia? That really is another factor in terms of prevalence.
Yeah. Yes. So the incidence and the prevalence. That's why the incidence is slightly different, and we had different gender effects in that as well. So what's a challenge for us is it's actually quite difficult for us to answer that question because we weren't funded for further follow-up of CFAS II. So despite showing the changes in prevalence and incidence, the funders, and we did try many times to get funding. It's not something that is routinely funded in the UK, the kind of background epidemiology, and it isn't in Australia either. There is a kind of gap in between surveillance investment and research investment, and it sort of falls in the middle. It's seen as a bit boring, measuring the occurrence and natural history of a disorder in a population. Because it's not doing, imaging or wizzo things, but actually it's fundamental. So we can't, it's difficult to answer that question, because if you look at routine stats, it looks as though people are living longer, but it almost is certainly, those routine stats are almost certainly because people are diagnosed earlier and earlier now, and the boundary between what's considered to be normal and dementia has sort of shifted so that we're diagnosing formally in routine systems people much earlier. It's a classic screening lag time coming in, so people appear to be living longer. So it's a difficult question to answer, and I wish I could.
Yeah, I understand there is one group that is actually looking at duration of illness, duration of time lived with dementia, because it's very important for insurance purposes, for example. And if you're offering insurance for dementia or for health economic purposes. And in fact, cosmic data are being looked at, because some of these studies are following their people even after they're died.
No, we have mortality. So CFAS, so I'm talking about sort of the onset. What you really need is incidence to death, and you need a standard approach to the diagnosis. So, yes, we have published on the duration of dementia, and it's different. And of course, it's very different in the younger people who have incident dementia live much longer than the people who are in the older age groups. But of course, that's only an average, and how much functional disability you have is very important, but not how much education. So we do have some of those findings from the original CFAS, but that was from incident dementia. But for CFAS II, that's much more tricky for us because we've only got one incidence point.
Okay. Thank you. So the other question is from Will Brooks. I don't know whether this is correct, because he says one of your slides showed a significant protective effect of general anesthetics. Was it protective?
Oh, yes.
It was, yeah. So how do you explain that?
Yeah, so that goes against the general literature. So I would, when we kind of dug into that, for that particular population, we believe that finding was basically the way in which the NHS worked was that if you had your cataracts done, your hips done, in fact, at that time, the replacement wasn't so great, but the things which actually are about maintenance of good aging probably boosted that effect. So the more anesthetics, because at that time, people were having general anesthetics for those conditions, or anesthetics for those conditions. And so those probably meant that you were getting better access to healthcare that was sustaining your healthy aging. I know that finding is not in line with a lot of the anaesthetics work that's come since. And of course, we can't distinguish in that group between who had the harmful, what are now considered to be the harmful anaesthetics, and the ones which are neutral for older people.
Yeah. We have actually a PhD student who's working on hospitalization and cognitive decline. And so even the fact of hospitalization, even if it doesn't involve surgery or anesthesia itself, seems to be detrimental somehow
Yes, well, yes, and that fits with the delirium literature and Dan's findings of delirium providing a kind of major knock to individuals, from which some sort of have a different trajectory, and I think that's really a very important avenue of research, which can be quite difficult to capture, but it's tracking people through hospital is really good. And his study is called Delphic, that he's doing in Camden Town in London now, tracking people through.
So Jessica asked this question just on your last few slides on understanding dementia in the context of sustainable development. How does dementia look like under the climate change scenarios? How can we conduct dementia research and think about how dementia fits in the population health in line with the sustainable goals?
Yeah, lovely. Well, I think we have enough evidence to really emphasize to politicians that if we really look at the policy, the evidence-based policies by age group, that we can create brain healthy policies at every life stage on the basis of the evidence base that we have, so aligning brain health and sustainability. And we're trying to kind of write on this as well. And I know others are sort of thinking in similar ways, but it hasn't really penetrated the dementia research world yet. But I think it has, in healthy brain aging, those communities that are interested in healthy brain aging, I think that community has got that, has got that in view, although it's not closely linked enough to the sustainability agenda. But I actually think that they can be mapped very, very closely together, and I'm keen that we do that and start to do research that really shows it from. It's a bit like a healthy life expectancy approach. You take the 0 to 5 and the 5 to 9, and let's say, what's the evidence base here? What are the trajectories of those risk factors into later life? How can we shift those in at that age group and just shift at every age? So aligning the agendas and not saying that we have to kind of do something dramatic about not having older people.
So it was very interesting that you actually brought in inequality, because there's so much discussion in the world about inequality and how inequality contributes to the different risk for dementia in the populations itself, and perhaps ties in very well with the sustainable development goals as well, because much of it is about inequality in the world, really, in so many different ways. Yeah.
I think if we bring the inequalities agenda into the sustainability and the healthy brain aging, basically we're tackling healthy aging at a blow. When people ask me if I could wave a magic wand, I don't say I'd like a drug. I say eradicate inequalities, and then we'd have a leveling up of the most disadvantaged. I mean, what I didn't show was the reduction in incidence. It's associated with inequalities. So between the first generation and the second generation study, we didn't find any differences across centres in the first generation studies. In the second generation study, we did. So the more advantaged had the greatest reduction, the least advantaged had the least reduction. So hadn't had the benefit. It's the classic inequalities story. So I think, you're so right, Pimenta.
I mean, that's one of the biggest challenges, I guess. The other challenge is, do you think, like your thoughts on it, can we dissociate dementia from aging one day? Because if we say that, look, the association between dementia and aging is that pathology is accumulating over time. And of course, aging is about lapse of time. So if we can stop the accumulation of pathology, the aging process can still occur, but dementia may not occur at the same time. And this is the argument that people actually put for, say, the anti-Alzheimer treatments, etc., is that you're trying to dissociate the aging process from the dementing process. Do you think that's likely to ever happen?
Well, I think we have to do thought experiments to say, well, what would that society look like? And what does it mean? What would it cost? Or what would it cost in terms of resources, for example? And the way that I tend to think about it is there's it's primary, secondary, tertiary in a way. It's the preventable, the treatable, and the mitigation once present. And I think that we've got very good evidence about the preventable now, but it's not about individual drugs. It's about health across the life course. And yes, some things will come in at certain stages, like effective treatment for diabetes or heart disease or whatever. And that plays its part, but actually the big thing is the upstream prevention. Then doing what we can with effective medications or whatever approaches to the risk factors once there. And then my own view is that because of the evidence that we have about changes towards the end of life, even in people who are very healthy across their life courses, that there almost always is some cognitive decline before death, that there will always be a component that is associated with the age bit. And that's where the gerontologists obviously are working to do these things like metformin treatments, which are anti-aging or is it rapamycin and so on. But the question is, what are we actually doing when we do that? I mean, are we really wanting to medicate the entire population? And if you look at other conditions, not just dementia, but cardiovascular disease, cancer, bone health, renal health, lung health, each one of those individual fields is saying, we must go earlier and earlier and earlier and do early detection. And we need to understand, what does that mean? If you put that in combination, what are we doing to 40-year-olds or even 0-year-olds across their life course? And actually, we have very, very good evidence that if we structure society in healthy ways, we can all live without thinking about our health until about, maybe into our seventh decades.
So thank you very much. We have two more questions. I think maybe you can take them and then finish. We've run out of time. But so the first question is about COVID-19. Can you tell us about the impact of COVID-19 on people with dementia and what might be being done in the UK to measure the impact of COVID-19 on development of dementia, if anything is being done? So
yeah, there's a whole massive research. Actually, I haven't got the kind of at my fingertips the whole scale of research that's done, but there was an enormous amount of, there was 1,000 flowers blooming, basically, an enormous amount of expenditure. But we're doing some work in CFAS, and we're looking at social networks and sort of people how have people's lives changed during the different lockdowns and the different policy strategies. But we haven't got to publication of those, but it's quite interesting to see who's missed with shielding and who isn't missed. Shubhi Banerjee has been doing work within the Determined study, which is about early diagnosis on basically on the people who are recruited, asking about the impacts on carers and so on. And that's research that's ongoing, where there's a couple of papers which are kind of in process. And there are a lot of long-term studies. So people have been, and I don't know if you've got them in this, you haven't got enough cases in many ways, but there are now longitudinal studies for neuropsychiatry.
There's a worldwide effort, and I think UK is contributing, unfortunately, actually in some ways, because you had quite a few cases in the UK.
Yes.
So in some ways, that's it also is a minefield for research. So the last question, I guess, is, have you ever looked at assessing people's psychological outlook, the way they cope with stress, etc., and the effect this might have on the risk of dementia and on cognition?
We had a very big bolt-on, psychosocial bolt-on in the just after the baseline in Cambridgeshire and Nottingham in CFAS. And we did all sorts of things like locus of control and sense of coherence and all of those types of measures. And we didn't find anything particularly strong, but it's data actually that is there, and with much longer follow-up there's a huge, rich data set. So I would say that that's still, there's more to be done. We didn't find anything in the early years when we were analysing those data, we found some immune phenotyping interest stuff with vascular outcomes, but the psychological measures didn't contribute that much, but I think it's well worth a revisit.
There is one more question that's come through, and that's about climate change, and I think that's topical as well. So Kylie Radford asks, okay, what do you think will happen to aging population, brain health over the next 50 to 100 years? especially in
Well,
relation.
yeah. Well, I think it depends on the success of the strategies at governmental and intergovernmental levels. I mean, I think we need to provide the evidence base as robust as we possibly can, and I think this kind of risk reduction approach, enhancement of protection of brains across the life course, with a lens of sustainability, is the way that we can contribute to that, and the contribution to, well, basically saying that, if you don't address inequalities, you'll always have a significant proportion who are at very high risk of your population, and therefore that, with the implications of what that means for services and so on. So I think that we really need to take a climate change lens to the way that we do primary, secondary, tertiary prevention, including our approaches to early detection, because that's hugely intensive in terms of resources, and think about it very carefully. Most climate change sustainability work has been more about kind of, let's mitigate the impact of climate change, so sort of the heat waves and so on. And yes, that's very important, but I think we've got to kind of broaden it out a lot.
So thank you so much again, Carolyn. It's been a wonderful lecture and wonderful discussion. And I think we're looking forward to the day that you'll visit us.
Yes, maybe I should come by ship, although I think that's pretty bad for sustainability too. So we'll have to work out methods of travel which don't contribute more to the climate.
That's true as well. Yeah. So thank you, and good morning to you. Yeah.
Thank you.
And thank you, everybody. What I'd like you to do is perhaps complete the survey that comes after this presentation. And of course, if you're interested in future talks, there are a number of talks happening in the next few months. Please subscribe to our newsletter or visit the CHIBA website. So thank you very much for your attendance. Goodbye.